welcome to another Piper Pod. Today we're going to continue with pathophysiology and we're going to look at the musculoskeletal system. Now obviously you could theorize that we're going to talk about thousands and thousands of conditions that affect the musculoskeletal system, but the focus of today is not going to be on trauma or repetitive use. We're only going to touch on that a small bit, and we're going to focus on the musculoskeletal conditions that you may not have looked at before or as much in the past. So a lot of congenital and a lot of metabolic or excretory type problems that affect the musculoskeletal system. So to start off, we'll just do a little bit of an overview of what the bones themselves do. So the bones' function is obviously to support the entire body and protect vital organs. That's pretty obvious. It also aids in movement as it has levers connected to the muscle, but it's also an essential reservoir for minerals like calcium, phosphorus and magnesium. It's a thing that people often overlook, is how much mineral is stored in bones that is able to be used by the body. Bones are also heavily involved in the production of all your blood cells themselves. Okay, so hematopoiesis occurs in the bone marrow of most of your long bones and your flat bones. Now when you look at the composition of what makes up a bone, you have what's known as a bone matrix protein, and this forms a framework in which minerals can be deposited. So the main type of substance that makes up these bone matrix is collagen proteins. Okay, and osteoids is the unmaterialized bone matrix responsible for giving bones that tensile strength. Now what tensile strength refers to is it actually makes them slightly bendable. Okay, so if you have impact or gross movement, that sort of thing, they don't shatter because they're not brittle. Okay, it's because of the osteoid bone matrix that allows this to happen. Now, as far as mineral deposits go, about 65% of all the bone mass is made up of these mineral deposits. Okay, and hydroxyapatite is the formation of calcium and phosphorus complex that mostly forms up the mineral deposits. And they're responsible for the hardening and the resistance to compression that bones have. So two types of bones that are available is you have your cortical, which is your really compact bones. They're responsible for load-bearing function and they're dense. Okay, and then you have your calcareous ones, which is spongy, and that's responsible for metabolic function. They're obviously more prone to disease and they're less dense. Okay, so your calcareous bones is essentially the inside of your bones itself, whereas your cortical is the outer, thicker layers that you'll find. Now if we take a closer look into bones themselves and we have a look at the type of cells that we find, we have the osteogenic cells, which are progenitor cells, and they form the periosteum and the endosteum, and they're obviously very, very important for renewing or rebuilding the bones. And then you have osteoblasts, bone formation. Osteoclasts are more involved in the reabsorption of the actual cells, and then your osteocytes, which is your mature formed bone cells themselves. Now when you go through remodeling, what generally happens is first of all your osteoblasts lay down, then your osteoclast comes along and reabsorbs most of the bone, and throughout your life this happens all the time, and it's heightened during growth and in fracture healing. Okay, so osteoblast is laying down new, and osteoclast is all about that remodeling, reforming and then absorbing stuff that's not needed, and osteocytes as your formed mature cells that you'll have. Okay, let's have a look at a few disorders that affect bone tissues. So the first one is achondrodysplasia. Now this is a rare disorder of the skeletal development, okay, and it's characterized by dwarfism. Now most of the causes is caused by a single gene mutation, okay, and 80% of all the cases are quite sporadic, which means you don't always get the full effect. Sometimes it can just affect certain areas. Okay, now whilst most of them has got to do with specific gene mutation, there are cases that you have the entire autosomal dominant condition that will affect and have similar characteristics. Okay, so when gene mutation occurs, it leads to an abnormality in the endochondral ossification. What that means is the growing and the formation of bone around that cartilage model. Okay, so that's what that term is. The cartilage model that we talked about, the formation of bones around it, essentially don't happen. So your long bones are subject to not growing. So they're not growing, they don't have the ability to expand through the epiphyseal plates from birth, but the development of flat bones and vertebrae is actually quite normal. Okay, so you'll have a normal torso, but you'll have shorter arms and legs, okay, for lack of a better term. Now, from the very rare to the quite common is we'll look at osteoporosis itself. So this is a term that's defined as the absolute reduction in total bone mass. Now, it's very age-related to the point that 1/3 of the population greater than 85 will have osteoporosis. Now, women are more likely to get it than men, and it's especially associated around menopause. Now, there's two different types. There's your primary osteoporosis, which the causes don't really know, and then the secondary osteoporosis, which is linked to other diseases. So if you focus on primary osteoporosis, there's been a few predisposing factors that has been linked to it. So initially, it's got to do with small bone mass already. So people with small frames, small growth plates, they're predisposing factors. Bad dietary habits, huge fat intake and smoking is huge. Age, okay, so age-related changes in metabolism, and then hormone dysfunctions, okay, mostly thyroid and the hormones associated with going through menopause are strongly linked to primary osteoporosis. Whereas secondary, that's linked to hormonal disturbances, so excessive cortisol or deficiency within the sex hormones. It's also got closely linked to dietary disorders, so vitamin C and calcium deficiency, and anything that causes malabsorption of food, like spirus and things like that. Long-term immobilization, certain drugs, and a metastasis from breast cancer as well. Pretty common causes of osteoporosis. Now, the things that occur in osteoporosis have to do with inadequate bone formation and excessive bone reabsorption. Okay, and certain things that trigger those or make it more likely to occur is inadequate bone formation is hindered or increased by reduction in physical activity and also inadequate intake of calcium. So either not eating enough, taking nicotine, caffeine or diuretics like alcohol can hinder the amount of calcium that's absorbed. Now, things that trigger excessive bone reabsorption have got to do with estrogen and testosterone deficiencies. Okay, so hormones normally inhibit osteoclasts. Okay, so the absence or the reduction in levels of estrogen and testosterone will no longer inhibit osteoclasts, so they're free to go through rapid reabsorption of bones. Now, as far as clinical characteristics go, you'll see pathological changes. People will shrink in height and they'll have a stooping deformasis, like kyphosis or a Dallinger's hump is what they call it. Obviously, they're more prone to fractures as well, and that's basically the clinical presentations that you'll find. But obviously, bone scans will show a reduction in the actual hardening of it. Now, in order to prevent it, hormone replacement therapy can be used, especially during menopause, and calcium and vitamin D supplements can be recommended as well. Now, two other conditions that you may not know too much about is Osteomalacia, which is, unlike your osteoporosis, this is more of a softening of the bone as a result of inadequate mineralization of the matrix itself. Okay, so the formation of the osteoid that we spoke about doesn't actually grow as well as it should. So the leading causes has got mostly to do with vitamin D and the malabsorption of calcium, or the disturbance of phosphorus metabolism. Okay, so just to remind you all what happens with vitamin D metabolism is you can get vitamin D in food. That happens. But most of the time you have ultraviolet light irradiating the skin, and that produces an enzyme or a form of peptide. And then that goes to the liver where it's metabolized and then it goes to the kidney, not for excretion, but the actual outer cellular structure of the kidney, where it forms vitamin D as we know it. Now, vitamin D is very useful. Obviously, it does a number of things. It increases the intestine's absorption of calcium. It increases the reuptake of calcium and phosphorus within the bones, and it also can stimulate the kidneys in order to excrete less and reabsorb calcium as well. So when you have a vitamin D deficiency, it can obviously come from diet or inadequate exposure to light, but then it can also be a failure to activate vitamin D. Okay, so if you have an enzyme deficiency in the kidney mostly, or the liver, mostly the kidney though, you'll find that you have the inability to finalise that vitamin D synthesis. Now, the clinical features that you'll find with Osteomalacia is bone deformity. You'll actually show deformity growth within it. It's almost like a spongy type tissue, and that can lead to fractures. Now, when it's found in children, it's actually called rickets, and that's characterised by children with bow legs or a widened costochondral junction. You can also get skull deformation and a delay in dentition as well. Now, osteomyelitis is obviously inflammation of the bone and the marrow cavity. Now, its primary causes are infections, bacterial, viral, and fungus. It's extremely common in children under 5, unfortunately. Now, two different types. We have acute and we have chronic. Now, acute osteomyelitis is an absolute emergency because of its rapid destruction of the bone. So an acute infection of the bone is considered a medical emergency because it rapidly destroys it. Chronic osteomyelitis causes a large amount of morbidities, like your pathological fractures. You get a lot of stunted growth, especially in children, and it opens up the increased probability of getting carcinomas. So the way osteomyelitis works, if you look at the pathogenesis, the pathogen, mostly bacteria, spreads to the bone via the bloodstream or directly seeding into the bone in the case of open fractures, things like that. Now, once it's in the actual bone, acute inflammation and localized inflammation of the narrow aspect of the bone, called the metaphysis. Now, this increases the risk of bacterial seeding in that actual area. So because of the inflammation, you have a greater possibility of other bacteria moving in and seeding in there. Now, from there, you'll get different things like necrosis of bone formation called a sequestrium. As the infection spread, it creates a sinus cavity that allows pus to actually drain through the bone and often get stuck in the skin formation itself. So when you look at the actual bone itself, what's suffering from osteomyelitis is you'll have a huge amount of spongy-like tissue surrounding the bone itself, and the internal structures can be really weak and degraded. Okay, we'll just have a quick look at bone tumours. Now, bone tumours, as far as primary tumours are concerned, only account for less than 1% of all tumours. Having said that, it is a very common site for metastatic deposits. So it's very common to get secondary tumours from metastases from the breast, the kidney, lungs, thyroid, and even the prostate. But looking at your primary bone tumours, the one that forms right in there, they mostly form benign or malignant, and they come from blood forming cells. So the actual specialised stem cells, myeloid cells, that are found in the bones themselves can cause the actual bone tumours, and then you can also have genetic changes to the osteoblast or class and the cartilage cells themselves. Now, as far as sites around the body go, there seems to be sites that are more susceptible to it. As you can see in the picture of the left, they have certain names like Ewing sarcomas and things like that that are formed in the absolute belly of your long bones. Okay, so they tend to affect those specific sites. Okay, we'll finish up with bones and we'll start having a look at our joint diseases. So despite the fact that there being many types of joint around the bodies, the diseases that we're going to focus on mostly affect the actual synovial joints. So just for familiarization, remember that synovial joints are those that will have fluid encapsulated within the synovial membrane. And they usually have associated fat pads for protection as well as bursas themselves. So the first very, very common joint disorder is osteoarthritis, which is also called a degenerative joint disease. It is the most common of all joint diseases, associated with wear and tear. It's also a disease of the elderly, and what it does is it affects weight-bearing big joints, small joints of the hand and feet. So as far as classification goes, we have primary, which again the cause is unknown, and then secondary, which is related to other diseases. For example, old fractures leading to abnormal load bearing within that joint. So weakening of bones, that means a huge amount of pressure is placed onto those bones themselves. Now when you look at the gross changes within osteoarthritis, what you will find is a loss of the articular base cartilage itself. And then you'll have bone spurs formation, and they're called osteophytes. Now what happens is obviously with the loss of the articular cartilage, you get exposure of that articular surface of the bone, and as you weight bear and you work on it, it starts grinding away, which leads to hardening of the surface of the bone, which does give you localized synovitis. Okay, so it's not subject to gross inflammation throughout the whole body, but you will get localized inflammation within the area itself. Now, clinical features that you'll find is obviously pain, crepitus, swelling and warmth of the actual joint. Now, as it goes on a long period of time, especially in the hands, you can get joint deformations. Classic one is your Herbert's nodules, which is like bony growths at the actual joints, and it looks like it's been pinched from either side. Now, as it goes further, you'll have a loss of your normal mobility. Now, another disorder that affects the joints is your rheumatoid arthritis, but this one here is associated with a chronic systemic disease. Now, the etiology is unknown. Okay, people often confuse it for rheumatic heart disease and that sort of thing, where it's a known link to your antibody production. But this one here, there's often antibodies involved that we'll speak about, but the cause itself is still unknown. Now, this one is characterized by chronic systemic inflammation of joints. Significant but not diagnostic laboratory findings will often find changes within, similar to immune disorders. Another very important thing to note is it's also associated with other extra articular findings, so signs and symptoms outside of the joint itself. So the way it generally works is it's known as a systemic autoimmune disease. Okay, so they know that there is an increase in rheumatoid factor, which is a production of like an auto-antibody. What they don't know is what causes this production of the antibody. Now, this causes inflammation of the synovium when you're dealing with arthritis, and exudation of fluids. Now, that leads to chronic proliferation of the synovial cells, and it will lead to a formation of granular type tissue. And this particular granular tissue is called your pannus, and that will grow around the articular cartilage as it is. Now, the pannus will contain numerous inflammatory producing cells, which secrete substances that destroy the articular cartilage as well. So the inflammatory mediators will actually destroy the cartilage, and means the pannus will eventually lead to fusion of the joint, which is called your ankylosis. If you were to look at the gross structural changes associated with rheumatoid arthritis, you will see erosion of the actual cartilage, joint swelling and loss of the particular cartilage as well. You'll also see that pannus that I spoke about forming, and an overall joint deformation. As far as clinical features, there is your pain, swelling and redness, which obviously can be insidious during its onset, but then may disappear and then come back during a relapse. You can see joint deformities, especially in the fingers, and a reduced mobility. But the main features that you need to look for to help diagnose rheumatoid arthritis is the systemic features. So the systemic features that you can find are, generally speaking, will have the low-grade fever, loss of appetite, anemia as well, so it affects the actual erythropoiesis, and you can get a general loss of appetite. Now, other things that differ from osteoarthritis is you end up with a polyarthritis, so most of the joints in the body actually have some amount of pathological changes. Things like lymphadenopathy and splenomegaly are also factors to take a look at, as well as Uranus phenomenon, which is discoloration and tingling within the hands. As far as serology goes, you will find changes. You have that increase in rheumatoid factors. Okay, rheumatoid factors will show an immunoglobulin G increase in number with an auto antibody, and they tend to bind and block your immunoglobulin Ns, which is associated with early onset of infections. Okay, another joint disorder that we commonly find in the military is our gout. So gout is defined as your hyperuricemia, so a huge amount of uric acid found within the blood, and it's accompanied by the deposits of uric acid crystals in various tissues. Now, gout classically is known as the joint, but you can also get these crystals that get put into the skin and even the kidneys. So it's a systemic metabolic disorder. Now, in primary gout, it's the buildup of uric acid that can be caused by metabolism, so overproduction of uric acid, and then a renal problem, which is the under excretion of the uric acid. So the way it works, which is pretty unique and interesting, is uric acid crystals themselves will actually deposit themselves within the joint space. Now, these crystals actually have their own version of chemotaxis, so that means that they attract leukocytes into the joint space. Now, leukocytes do what leukocytes do, and they attempt to go through phagocytosis on the crystals, but they can't. They can't actually break down the crystal, and the sharp crystals will actually pierce through the leukocytes, leading to leakiness and the destructive enzymes like lysomes and cytokines being released into the joint space, causing that inflammatory changes. Okay, so you'll end up with an augmented response of inflammation because of the uncontrolled release of lysomes causing protein destruction and cytokines causing your actual acute inflammation. Now, two different types of gout that you can have is in the acute setting, usually happens in the feet. You'll end up with a massive attack, and you can get this red, swollen, hot nodule called your protogra. And protogra looks like a massive boil on your great toe, and you can also get systemic features of fever and malaise. Okay, especially when some of the leukocytes that are destroyed is your lymphocytes and macrophages, obviously releasing pyrogens as well. Now, the chronic gout, believe it or not, is actually less pronounced forms of inflammation. So you'll get the joint deformity, but you can also get subcutaneous deposits of this uric acid as well, and they're called a atrophy. Now, this can unfortunately lead to nephroliasis, so a special form of stone formation within the nephrons, which can lead to your chronic renal failure. Okay, we're just going to quickly have a look at some trauma conditions, obviously just focusing on general overview itself. So a fracture is a disruption in the bone continuity caused mostly by mechanical factors, okay, commonly trauma. It obviously has pain, deformity, and the inability to move the limb. Now, as far as classification goes, we have simple, which is just two fragments of the bone. You have comminuted, which is multiple fragments. Complex or complicated, which is a fracture line extends through the entire thickness of the bone. Incomplete is more like your green stick, and then open compound breaks through the skin, and then closed is underlying the skin. Now, fractures occur when there's structurally abnormal bone that cannot withstand the normal pressure of tension, or obviously with great trauma. So when there's structural problems, it's usually associated with things like osteoporosis, chronic osteomyelitis, and even the Osteomalacia that we spoke about. So there's some pathological things that will cause fractures. Now, when you're looking at healing, they require complete immobilization, which can either be casting or surgical realignment. Now this helps preserve the granulation tissue which surrounds the spongy bone that will further grow a calcis formation. Now once it's healed, the remodeling, restructure of the bone will occur, and in time it will restore its strength, and the spongy bone to the cortical bone will be repaired as well. Now things that we want to do to promote healing is you want to promote immobilization, you want to promote compression of the fragments, so you don't want it really loose. Obviously too much compression is a bad thing, but too little compression and you'll actually get the bone growing really, really large. Deformation can lead to tendinopathies. And then you want an adequate blood supply. Things that delay healing is obviously your infections, the presence of a foreign body, but malnutrition, so things like calcium, phosphorus, vitamin D, they're obvious ones, but also vitamin C is very important that most people don't pay a lot of credit to when you're dealing with reforming of bones. But vitamin C is very important for the formation of type 1 collagen. And that's the collagen that's found in the actual protein matrix of the bone. So without it, you won't get that protein matrix that the mineral beds can actually fall into. Now looking at dislocations, you'll have dislocation or luxation is a bone forming at the joint which loosens its contact and therefore becomes misaligned. Now commonly caused by excessive force or movement at that joint and can cause by structural weakness, ligamentous laxity, extended ligament damage, things like that. Now when you have a particularly violent dislocation, it can lead to trauma associated with the ligaments as well. And the term subluxation is just a partial dislocation, it's not actually fully out. Now you're going to get pain, you're going to get localized swelling, but the main thing to look for is the reduced mobility and the deformation itself. Now these dislocations can often go hand in hand with your sprain, which is the stretching or tearing of a ligament. It's usually a result of excessive force, and abnormal movements can be associated with dislocations too. Whereas a strain is association with a stretching or torn tendon or even muscle that is usually the result of excessive force itself. Something else that can affect tendons is your tendinitis, or what is also known as tendinopathy. So there's a bit of debate whether or not tendons or tenocytes can actually become inflamed, and they often think that it's just got to do with misalignment that causes these classic tendinitis, which will be called your tendinopathies. Okay, but because the debate's still out, tendinitis is inflammation of the tendon or the surrounding tissue. It's commonly caused by overuse. Okay, so tennis, golf, and then there's even, sad as it is, something called the Texter's thumb, okay, which is your de Quervais's syndrome. Yep, it's happened, de Quervais's syndrome. They have warnings about it. It can also be caused by trauma. Now in that case you'll get restriction in the movement and pain and swelling on that sort of the area itself. Now bursitis is a little bit different, and when you see it you'll definitely know it. So the picture to the right is a classic bursitis. It is definitely a result of trauma. It can also be overuse, so you always on your knees working, bumping your elbows, that sort of thing can cause it as well. Now your bursas are like your fat pads, but they're fluid-filled sacs that are used for absorbing shock pressures. Okay, so when you get it, you'll get gross swelling and redness, and generally pain as well. Okay, to finish up, we'll have a quick look at our muscle disorders. Okay, so when we look at the muscles, just a few things that we need to be familiar with is the muscle cell itself is very, very large, and the cell is made up of specialized protein structures called myofibrils. And then you get the bundles of myofibrils which create a muscle fiber, and then they're cased within a sac. So your perimysium, epimysium, those sort of things. So they're filled within the actual sacs itself. Now, skeletal muscles, believe it or not, are what's known as post-mitotic cells. So they're terminally differentiated cells, which means they're not going to change. So they're not really subject to your DNA changes or anything like that, because they cannot divide. And you may be thinking, if the cells can't grow, then what actually makes hypertrophy and that sort of thing is actually just the implantation of more protein fibers causing myofibrils that will actually cause your muscles to grow. Another thing to bring back to your memory is something known as the neuromuscular junction. So that's the site between the axon and the muscle fiber itself. Now that is controlled by the neurotransmitter acetylcholine, and it binds to the receptor site of the surface of the muscles itself. And this is what initiates that initial contraction. If you want more information, there's the second video on the anatomy physiology of the muscle is all about how the muscle contracts itself. But in simple terms, the neurotransmitter stuck in the actual cleft is removed by the enzyme called cholinesterase. And the actual signal to the muscle fiber is what causes the muscle fiber to actually maintain and grow and be utilized. Now the reason I bring up on that is when we start looking at our neuroadrenic atrophy, that is a condition defined as a form of muscle cell atrophy caused by an injury to the nerve itself. So the lack of stimulating fibers to a particular muscle cell, so the message not getting through, will actually cause that muscle to shrink and atrophize. So the muscle cell requires this nerve impulse to contract, and it's the contraction that is needed in order to maintain its normal size. If not, the body sees it as something that is not needed and breaks it down for use in other muscles. Now the nerve injuries itself can occur at different levels within the central nervous system. So you have an upper motor neuron and then a lower motor neuron itself. Now a single cell, if just one cell results in atrophy, then that can be reversed. Okay, your body can just get picked up by neighbouring neuromuscular junctions, and it can be reversed. But if it's an entire motor nerve that's affected, then often means long-term or permanent atrophy itself. So things that cause upper motor neuron injuries are conditions that affect the brain and the spinal cord itself. So you've got your stroke, your spinal cord injuries. Now this can cause paralysis, which is loss of power and the ability to move. You've got paraplegia, paralysis of both legs, or then hemiplegia, which is a paralysis of the muscles on one side of the body, usually as a result of stroke. Now your lower motor neurons, this is an injury to the anterior horn cells within the peripheral nerves. Again, if you need, then go back and look at anatomy physiology. But these are mostly caused by diseases like poliomyelitis, Guillain-Barré syndrome. Can also be caused by trauma, disc prolapsing, and then you can also get a diabetic base neuropathy as well. Now, Myasthenia gravis is a rare chronic autoimmune disease involving the neuromuscular junction. So it's characterized by an impaired neural impulse transmission. Now it's more common in women than men, unlike the picture to the right showing you. Now what happens in Myasthenia gravis syndrome is, being an autoimmune disease, antibodies will form against the postsynaptic acetylcholine receptors. Okay, so as you can see in the picture, you've got the antibodies and then you've got the blue acetylcholine receptors itself. Okay, now the antibodies will block the receptors from being occupied in the neurotransmitters, which means that the message isn't getting passed on. So there's no action potential actually being passed on. Now, eventually these antibodies will damage the receptors, okay, because they'll encourage in sticking together, breaking it down, not being stimulated, so the receptors will break. Now this leads to increasing muscle weakness, especially of the facial and the extraocular muscles. But all muscles can be affected by this syndrome. So clinical features is easily fatigued when doing simple things, even like reading and chewing. The muscles can get very, very fatigued. You can get ptosis, which is droopy eyes, which you can see in the picture to the right, but then you can also get diplopia, which is double visioned. So the coordination movement of the eyes is required for a single image within the retina. So fatigue of the extraocular muscles can lead to uncoordinated movement of the eyes, therefore people can see double. Now, unfortunately, this particular disorder can also lead to death, especially if the intermuscle or diaphragmatic muscles are paralysed. Now, symptomatic treatment can be available, but there's no cure for this itself. The last disorder we'll look at is Duchenne's muscle dystrophy. So this is the most common form of muscular dystrophy. Now, it is X-linked recessive disorder. And what that means is only boys can get it. Girls can be a carrier, but only boys can actually get it themselves. And what happens as a result of this mutation is it actually changes the coding for an integral structural protein called dystrophin. So dystrophin is used in muscles in order to anchor the cells together. So what you lose is that tactile strength associated with anchoring the muscles together. So the pathology is obviously muscle cell degeneration. So you lose muscle fibers and therefore you have muscle weakness. Now, what happens as a counteraction is you actually get compensatory hypertrophy. So hypertrophy occurs in the normal fibers not affected, and you end up with a massive ingrown of fibrous and adipose tissue as well. So you basically have a misalignment of your muscle structures. So eventually, all muscles will be replaced with this fibrous or adipose tissue, unfortunately. Now, clinical features is obviously you'll have weakness, walking, bearing muscles, especially in the pelvic girdle and the lower extremities. You'll have difficulty standing from a squatting position, especially in preschool age. Now, the picture to your right denotes the classic way in which people who suffer from Duchenne muscular dystrophy will actually get up from a kneeling position to a standing position. Now, by the age of 10, you'll actually have contractures and deformity of the extremities and trunk. Now, eventually, this will lead to loss of respiratory muscle and respiratory failure and death by your early 20s. So the patient's lifespan is greatly affected. Now, there's a different type of muscular dystrophy called Becker's muscular dystrophy, which is a milder mutation of the same gene that causes Duchenne's, but the symptoms are less severe and the life expectancy is much longer. Okay, that's the end of pathophysiology for the musculoskeletal system. I hope you got something out of it, a little bit of a different insight at least. And until next time, take care.